I don't see that.
Oh, that's the email. If we want to predict the email.
Good morning and welcome to the March 27th, 2024 Board of Health meeting. Good morning, everyone. Maybe we have introductory guests to staff. Please.
Yes, we have two staff members that we're going to introduce.
Sure. So we're very excited to reintroduce Ariana in a new role and then introducing Daniel in to the health district. So we can start with Ariana. Do you want to talk about your previous position and your promotion?
Yes, so I was previously a public health technician with the BCCHP program. And just recently got promoted to the public health partnerships coordinator. So I'm just really excited to be working alongside a very hardworking team.
Thank you, Ariana. We're very excited to have offered her this promotion. She has a background in public health, is very organized and dedicated. So we're excited to use her skill set in the department. And then we're welcoming Daniel.
So I'm a Washington State licensed teacher, coming from Children's Village. I was there. And now in my new position as a transition specialist, I get to try to involve the community in helping our kids with disability. So we're chugging along, trying to get all the school districts on board and participating in our Job Foundation program.
Thank you, Daniel. So we're again very happy to expand the developmental disabilities program specifically. So he'll be working along Steve Danston, who you met a couple of months ago as well. So we're happy to introduce them both, but they will be stepping out now. And thank you.
Welcome to both of you. We're happy to have you on board with the Health District.
Thank you.
Okay, and then we do have one guest.
I'm Jennifer Maxwell. I'm a family physician. And I'm just really excited to be here. I feel that an important part of taking care of our community is being aware of the work that the Yakima Health District does. Thank you for welcoming me.
Welcome. Thank you, Doctor. Do we have anything else for public comments, Ryan?
No public comments.
Okay, great, thank you. So we will move to the consent agenda where all items below will be considered routine by health board and will be enacted by one motion. There will be no separate discussion of these items unless the board member requests, in which event the item will be removed from the consent agenda and considered in its normal sequence of the agenda. Does any member of the board desire to remove an item from the consent agenda? If not, I'll entertain a motion to pass it.
I move that we approve the consent agenda as described.
Second. Thank you. So we have a motion by Commissioner Langley, second by Commissioner McKinney to approve the consent agenda. Well, I'm sorry, I'm ready. Please go ahead.
Okay, so February 28, 2024, Yakima Health District Board of Health meeting minutes. And payment of accounts payable and payroll issued in February 2024 in the amount of $878,495,71.
Thank you. So we have a motion on the floor. All those in agreement, please say aye.
Aye.
Any opposed? Motion passes. Thank you. Now we move to the Yakima Health District Spotlight. That's going to be Sean.
Good morning, everybody.
Good morning.
So this morning, we're going to be discussing partnerships to address nitrate contamination. This presentation will focus highly on the Lower Yakima Valley Guama, or groundwater management area that we have here in Yakima County. Next slide, please. So nitrates are a naturally occurring chemical when nitrogen and oxygen combine. They are essential for plant growth. However, when in excessive amounts in our soil and in our groundwater, they can pose health risk to vulnerable populations. So looking at sources that contribute to high nitrogen contamination in groundwater, in turn, in our wells, we're looking at fertilizers that contain high nitrates, looking at human and animal waste, leaching into the ground soil, which eventually will reach groundwater, leading to excessive amounts of nitrates being drawn up by our drinking water wells. So drinking water with high nitrate contamination, the limit considered is set at 10 milligrams per liter for our safe drinking water limits. There are associated health risks for infants and pregnant women, the most concerning one being methemoglobinemia, the baby syndrome. I probably botched the name. I'm sorry to the medical staff in the room.
Sounded great.
This is one of the major health risks we're looking at preventing when talking about high nitrates in groundwater. There are a large amount of residents in the Lower Yakima Valley, roughly 24,000 that rely on drinking water wells. Currently, there are around 2,000 wells that are at risk of high nitrate exposure in our Lower Yakima Valley. Next slide, please. So when we're talking about Lower Yakima Valley groundwater management area, that's Guama. That when I talk about Guama, that's what I'm referring to. So moving forward, I'll say Guama. Long name. This Lower Yakima Valley was designated as an environmental justice community back in 2009 due to the high nitrate contamination. This brought local agencies, state agencies, the federal government to be involved in looking at solutions to reducing nitrates in groundwater. In 2012, the Guama was established and with that, the groundwater is an action committee. Anyway, this was a group of state agencies, federal agencies, local agencies, local environmental activist groups, the agricultural community all came together and met for years and years and years on how best to resolve the nitrate contamination of groundwater in Lower Yakima Valley. Currently, this area is, the WAMA is overseen by the Implementation Committee, which is made up of a few local agencies, state agencies, the Dairy Federation, and several members of the ag community to implement our plan for reducing nitrates within the Guam. So that is ongoing work. Every agency has a list of its own items they're responsible for seeing through to execute the implementation plan for the Guam. Next slide, please. The work this group has done, both directly involved with the implementation committee and separately by individual agencies, has led to a lot of initiatives around nitrates in Lower Yakima Valley. Specific to us, what our role is in this is, number one, community engagement. We want to inject resources and information, education to the community, but also receive input from the community around what they don't understand, where trust issues with local, state, or federal government might lie, and how we can address those. What parts of this working relationship do we need to build up to be the most successful we can? As well as providing safe drinking water options to the community that's affected by this. Creating data and a network so we know where concentrations of nitrates are moving or fluctuating, where other areas are currently at risk through well water testing. And again, education to the community is paramount in the success of these initiatives and the future of the Guam. Some of the initiatives we've done more recently, or at least been involved with, is a pilot program to deliver free bottled drinking water to a number of households that have high levels of nitrates within the Guam. That's the initiative we were talking about that included, I believe it's fluctuated between 40 and 45 households for the last year and a half. We've also, with the same funding, conducted surveys to residents and local organizations within the Guam to offer education services and also build data points and for us to use in future initiatives. And gauge where the community is at in terms of nitrates in groundwater, what their understanding of it is. Our data shows that there's still need for additional education and resources in the community. There's additional need to sit down and have conversations with residents with multiple goals, help them understand why nitrate contamination in groundwater is a concern, what it means for them, what they can do to help solve the issue, and build that working relationship and trust between community and local government. Next slide, please. So in some of our work with the community, how we've approached it is conducting focus groups with different stakeholders, activist groups, subject matter experts, people who want to be involved in addressing this issue, and also just residents of the Lower Yakima Valley that are affected by this, with the goal and helping them understand what nitrates are, where the gaps in their education around nitrates might be, where more information needs to be put specifically within the Guam. Also to get feedback on what they would like to see happen. What different things could we do that they could buy into and have a better success rate in resolving this issue. As well as our surveys were conducted during this focus group and also sent out outside of these meetings and groups and events to households that were within our pilot project for water delivery and different well users around the Lower Yakima Valley. That was intended to give us data and feedback on where the community's at and their understanding overall for nitrate contamination within the Guama. Next slide, please. So looking at some of the data of these surveys, we can see that in response to just over 100 people, 110, I believe, we have primarily English-speaking population that responded, still a good number of Spanish speakers. Some of the concerning things about this data is looking at reasons for not testing water is they don't know how to do it, they don't know how to start. And you know, outside of doing what I do every day, I guess to some people, that's not something you think about and don't even know where to go with that and ask questions. So that's a piece of information that we can inject in the community to educate them on how to do that. A fair amount of people said it's too expensive for them to afford. Water sampling is not necessarily cheap, depending on what you're testing for. And a small number said they only drink bottled water anyway, so. About a third of folks said didn't even know what nitrate was, which again is a concerning data point to me. Is I want everybody within the Guama to know what nitrate is and what are the concerns surrounding that and what people can do to prevent exposure from high nitrate contamination. Good news I get from this is a vast majority of people who answered in this survey consider well water safety and education to be important. So there's a willingness to learn and a willingness to accept information. Next slide, please.
Do you know what the average cost was for a family to test their own well?
I mean, we have individual pricing. I'm not sure. For us, it's just under $50 for nitrate in California.
I can comment. So depending upon, as John mentioned, depending upon what you're testing for, but typically, so if you are financing a home, you're required the lender actually requires it. And usually, you know, it's about $184 to $384, depending upon what you're testing on. It just depends, but that's typically the one and only time that it happens, because as you said, this is not unique as far as the statistics that you showed for just this Guama area. This is universal. Most people who purchase a home and have said, well, let's just set it and forget it. It's tested one time when they purchase it and they don't typically go back and test it again.
And it's like medicine. Sometimes people have an apprehension that if they look for something, they'll find something and then they have to address it, which can be quite expensive at times.
Absolutely.
How often do you make recommendations on how often they'll have a well tested?
Once a year.
Once a year.
That's the standard. If there is a trigger level, so for nitrates, it's 5 milligrams per liter is the trigger, as in you should start looking at this, recommended for 6 months.
Are there like test strips or something cheaper that could be used?
We'll get to that, yeah. We'll get to that in this.
Yeah, because once a year at $100 and something for something give me a lot.
Well, if you know what you're looking for, so in this case, you're not needing to use the full test and tunnel.
Yeah, you can pare it down as to be more specific. So jumping into what we're working on today, currently, is our Safe Drinking Water Initiative. This initiative is launched by Yakima County Public Services in partnership with Washington State Department of Health and the Health District. This was being done through funding provided by the legislature with program goals of identifying and mapping out different areas of the Guama with impacted households. This is really going to show us where, if you want to call them hotspots, or the majority of the problems could be. And we're getting people that with past data, we know this historically to be the most affected areas. Getting those areas through the program initially and expanding from there. Also to provide education, again, to residents through this initiative. It's another opportunity to educate more people. Also to offer, of course, free nitrate coliform testing through a certified laboratory and provide safe drinking water alternatives for the folks that enroll in this initiative. This is started in January of this year and will run through June of 2025. That's the window we have with the current funding. Next slide, please. So how to enroll in this initiative is the County Public Services is conducting, again, targeted outreach. You can't read the map, but you can see the different blocks of colors up there. Those are the different phases that people who live within those areas will be receiving packets in the mail with all the information around this program, how to get started, how to enroll, how to move through all the different steps to get to the end goal, whether you have low nitrates, a trigger level nitrates to exceeding the safe drinking water. There's also a webpage and a hotline the county has implemented that anybody within the Guama can call or get online and enroll in the program. So that is an avenue in which people who are outside these priority areas or phases can still be involved and get their well checked out through the health district. The test strips that you asked about, this is where they come in. That's the initial step to this. Folks will receive a packet with instructions on how to use a nitrate test strip. They test their water under their kitchen sink, their bathroom sink, whatever, under the faucet. And they send the results of that test strip back to Yakima County Public Services. And based on that result, and based on whether you are a resident or owner of the household, you will, if you're a tenant or a renter with high nitrate, and we can't get permission from the property owner to go on site, they'll immediately get referred for bottled drinking water. And we'll provide the bottled drinking water to the tenant. If it's a homeowner or the homeowner's granted us permission, we will then go on site and conduct our site visit. Next slide, please.
Sean, my eyesight's not great, but is Sunnyside, the municipality, completely excluded on that map?
The city of Sunnyside?
Yeah.
Yes, as of right now.
Okay, sorry, because that's like the second largest population density from Yakima to here.
Yeah, and I think it's because the well users are so sporadic within city limits. There are quite a few, but it's not, we can't say, oh, every house in this area is a well.
Well, typically they're on the city water, but you're right, with some exceptions, so they're not gonna.
The outliers.
Yeah.
Next slide, please. So our site visit is conducted by our environmental health specialists. We go to the home. What we're doing, one of our main deliverables is to collect a water sample for nitrate and coliform bacteria and get that back to the lab same day. However, we're also performing a survey for the household, just get different demographics of the household, who lives there, the age ranges, asking questions around their knowledge around, well safety, well maintenance, knowledge about nitrates, just kind of get a baseline for where they're at in their knowledge of this issue. And then also we're evaluating well conditions. We're pulling septic records, well logs, and then taking pictures and just looking at site-specific conditions of that particular well. We package all this information up and we give that back to Yakima County Public Services for their database, their use, and then also so they can send results back to the homeowners. Also, when we make our site visits, we're providing additional education documents, having conversations with these folks on what they can do to help out their own situation based on what we're seeing. Next slide, please. So once the lab result is returned to us, if it's over the 10 milligrams per liter, homes are encouraged to enter the bottled water delivery program. This is a limited type program. I'll get to why in a second. However, folks that exceed the drinking water limit for nitrates will be encouraged to sign up for bottled water. Yakima County will give us the referral when someone accepts to be entered into the program. And then we will just add them to with Culligan Water's route deliveries with the contract we currently have with them. So it's a really simple process. We get the result within a day or two. They're signed up for bottled water. we're letting Culligan know how much water that specific household needs and they get incorporated into the delivery route. So within a week or two, depending on when the last delivery route was done, people are getting alternative drinking water. Next slide, please. This is the end goal of this initiative, is providing treatment. Reverse osmosis point of view system is going to start being offered in April to households with nitrate exceeds. The point of view system is a system that will treat one faucet. Typically, we see the kitchen sink being treated because it's the most high traffic faucet being used in the household. Drinking and cooking are the main concerns here, and we want to get that water treated. This program will cover the installation and 1 year's worth of maintenance on that treatment unit. However, regular maintenance is essential, so we are looking into the future, us, the county, DOH, on how best to potentially serve those treatment systems in the long term.
How much does a reverse osmosis system cost? At least.
It depends highly on the system and the quality of the system. I'm not sure these systems are being sought out by Yakima County Public Services. So we're just communicating to the folks that this is what's going to happen, eventually. But I've seen them for as little as 150 all the way up to several $100, depending on the quality of point of use system people are going after.
For the cost for this, the filters themselves or the use filters will be cheaper because we'll be able to buy them in bulk. The main expense is going to be the installation, hiring somebody to go in and install it. That's what we're still working through that piece at the moment.
So if you're saying you'll provide maintenance for a year, you'll provide the filters for a year, is that correct? Now.
Yeah, for like a plumber to go out or Culligan or a professional to go out and change that filter.
Okay, how long do the filters last? I mean,
6 months to a year, depending on contamination levels.
so when they need a new filter, can they buy that at a lesser cost because we're buying them in bulk? Can they buy directly from the,
At this point in time, no.
okay, so they would just be then have to go market.
Yeah. After the year expires, they would be on their own for the service and maintenance of the.
This will depend on future funding asked from the state legislation and DOH. So it's all being planned out and trying to ask for more money. Next slide, please.
I guess just a side question, but if they were drinking contaminated water and then they were to have a filter installed and they were not to change the filter, are they getting a higher degree of contamination using a dirty filter than they would be if they just drink the water straight?
Potentially, yes.
Yeah.
That's why maintenance is essential.
Well, if I remember right, this isn't a newer prescription that we've applied to the Guama. And in fact, I thought I heard that a lot of folks would actually unplug it and quit using these prescriptions, and that created a problem in itself.
Yeah, yes.
That's why we're having to look at a continuing maintenance program at the cost of the taxpayers to fund.
Yeah, filters that we have found, and we've seen them out in our field work, the ones that didn't have an ongoing maintenance program with it, they were either not maintained or they were, like you said, unplugged. Different programs through the EPA that provided point of use systems, those ones are still being used, still being maintained and still effective. So yes, ongoing maintenance. However, that can be planned out to be successful is absolutely vital to the success of these systems.
And Commissioner, this isn't the first initiative to try to put these in. In fact, we found in years previous that many people just wouldn't accept the systems. So even though there was an issue and we knew there was an issue and their residents, they didn't want the system. So that's one of the reasons why we're so committed to the community.
Well, I think that actually harkens back to the original point, which is that education is the role of government here and allowing people to consume the information, but ultimately action and longevity is up to each individual. There has to be responsibility. And some people will choose not to, and some people will choose to, but just like owning a home or renting, there are certain things that you do to maintain your living space. And if this is something you've been alerted to and educated on, it is then your decision to take action or not.
So, and kind of a follow-up to that, so if somebody decides not to use a cistern, they just say, I just want to stay on the drinking water. Is that an option for them to stay on the drinking water delivery program, or do they then pick that up themselves?
At this point, no, they're being told that this is, you know, for a maximum of this amount of time until these RO units become available. The funding, there's only so much funding to allow the drinking water deliveries to go.
Okay.
And Sean, one follow-up question on the, you were talking about the residential wells. Are commercial wells monitored by mandate?
Yes, this initiative is only for private wells, so individual and two-party shared wells. Group B and Group A systems are actually regulated and required to do certain amount of sampling and required to have a certain level of treatment, but based on their contamination levels. So they're being done outside of this initiative.
And commercial and ag wells for ag and dairy and orchards would all be
Different set of
monitored,
regulations, yeah.
but they are required to be monitored.
Yes, they are required to sample. Depending on how many workers they serve and all that, it would be, you know, Group B or Group A, community, transient or non-transient. It's like a gas station is a transient water system. The well serving, you know, what's the big milk place down in Dairygold, yeah. Well, during Dairygold, for example, that would be a non-transit system, but they still have a set of regulations.
They prefer to be called Big Milk Place.
I've been down there. Anyway. But yes, there's oversight and regulation for the commercial water systems. So looking at our overall objectives through this initiative is we have funding to conduct site visits for up to 665 households. That's water samples and surveys. We have the funding set aside to provide bottled water to up to 200 households. That's flexible if for whatever reason we have to go over that amount. I don't foresee that we will. By the time we get to that amount, the RO systems are going to be available and start getting installed. And then transition households to the reverse osmosis systems once they're available. And again, provide as much community education and involvement as possible to bring awareness within the Guama about this issue and what people can do to help themselves in partnership with local government and different local organizations to reach as many people as we can. Next slide, please.
Absorbing through the skin?
No evidence of that in any real concerning amount. It's ingestion. Looking at our strategic goals, one of our mandated services, even though we don't regulate private wells, is community health and safety and safe drinking water. So working with our partners within the Guama on providing options for that is something that we feel that we play an important role in. Developing a network of community partners. This is really as good as it gets. I mean, we have multiple state agencies, multiple local agencies working on these issues collaboratively. Nothing gets done in the magnitude that it's being done without everybody that needs to be being involved at the level they are. So we play a role. It's a vital role, but we are being very much a support agency in this initiative. But again, being in boots on the ground to help this initiative move forward and have the best possible outcomes is a vital piece of it. Increase the efficiency and effectiveness of district services. I mean, when we're looking at the effectiveness, we're reaching more people than we have within the Guama. Through our education and outreach efforts and relationship building that we've done, you know, we're already approaching. I think we're over 100 site visits scheduled, and we're in month 2 of this. I think several years ago when we offered free water sampling, there was, I believe, less than 200 done throughout the life of that initiative. And that was just come get your well tested. We'll do it for free. This is following on the coattails of a lot of community events, focus group surveys, and a lot of awareness being brought into the Guama. So we're seeing a lot more people get involved. We're hearing from a lot more people. So we're hoping that we can, execute the maximum amount of this funding set aside for this initiative. So we're working hard to be as effective as we can in reaching as many people as we can. Any questions?
I actually just wanted to share a quick anecdote from one of the team members that's working on signing people up for the bottled water delivery. There was a young family that had recently moved into one of these areas. They received a mailing and they just were very grateful because of the mother was actually pregnant. And that's one of the high priority areas to making sure that people aren't drinking contaminated water. Their water ended up being contaminated and had really high levels of nitrates. So we immediately signed them up for the bottled water delivery program and essentially cut that risk out of their life. So just one of the many stories in terms of the impact that's being seen across the community. And that's essentially who we want to reach, are those most at high risk, being that pregnant mom and young children.
Sean, how long does the contamination remain in the soil and the groundwater?
I haven't looked, specifically at that. Obviously there's sources that are contributing to the ongoing contamination of nitrate, but I think with anything that's leaching through the soil, it moves as groundwater moves and as precipitation pushes it down. So with a climate like ours, probably safe bet to say it's going to be there a while before it would have the opportunity to flush out.
And it would require no further introduction of nitrates into the system.
Yes, yeah, reducing the source of nitrates being introduced would be a big part of that.
If possible, because it's also naturally occurring.
Right. Yeah, there's many variables on how this is happening.
Right. Well, first of all, I'll say, I was actually living in one of those focus areas and I actually had my well tested by the group. So that went well. It was nice to actually see it firsthand, the process. And my well got a clean bill of health, which I was pleased with. Just for some perspective on this, 2 lives ago, I was a farmer, and in 1996, as a dairy farmer, we had several farms in our area who were sued over this, well, basically, not specific nitrates, but just pollution in general. And some of them I will say had practices that probably weren't the best, and you couldn't defend them. Many of them, I think, were targeted because they had deep pockets or perceived to have deep pockets. Nevertheless, there was an issue to address, so we actually went to the legislature that year to develop a farm plan so that there would be process in place to test your fields, to make sure that anything that and this should be whether you're talking about animal waste as a fertilizer or you're talking about commercial fertilizer. I mean, it's prudent to actually do regular soil tests so you know that what you're applying to the ground isn't exceeding what your actual crop need is. So any good farmer should be doing that. That having been said, this is looking at this down the road. I have to wonder about the scope of the program. I think Commissioner McKinney, when she said, really the key focus is education, I think she's right here as a primary responsibility because obviously there's a level where this is harmful, but when it seems like the 10 milligrams seem, well, any measurement's going to be kind of, or cutoff's going to be kind of arbitrary, I suppose. And the thing that I keep going back to is like, okay, when we look at cases of methemoglobinemia, I had to practice that. Okay, so when you look at that, we don't have any reported cases in this area as an area that's a target, a high risk area supposedly for this issue. And so I just wonder, I'm pro education and I'm pro proper management of soils and all that, but I just kind of wonder if that level of 10 is really the correct level or not, or it ought to be something higher. Because we're just not seeing people come forward and say, yes, we are suffering from this illness that we're at risk of.
That's what I was wondering, is it like what prompted this program? Was
Part it's
there an
lawsuits.
outbreak, or was
Yeah.
it something, was there illness that happened that?
It's activism. When you have activism, it highlights something, and then, of course, if you're talking about something as important as water, obviously that grabs the attention of legislators and, nobody wants to have anyone have ingesting anything that's going to harm them or children. So there's a hyper focus, as it should be. But, again, the reality is that this is very much naturally occurring as well. And it's not just unique to this area. It's not unique to this state. In fact, I think we could be very proud of the clean water that we have, not only in Washington State in our area, but compared to most parts of the world, we're doing pretty darn good. And to Commissioner Lindy's point, I would say it's because I think there's a lot of overregulation and trying to regulate to zero, which we saw during the pandemic, which is the idea that, we're going to drive towards zero, which because when you have people who are make personal choices as they should be left to do, you're not going to have 100% participation. And we need to allow people to have that right. And so I know probably anyone listening probably thought, well, why don't we regulate private wells? Well, that's because most people don't want to have the government involved in requiring them to have an expense to test their well. Is it best practice? Do we recommend it? Absolutely. But you want to have the freedom to choose. And that's why the role of government ultimately should always be education and let people make decisions.
Well, one of the things that we're also thinking about long-term in terms of the health of our community is the fact that we have so many older wells, and we certainly have older septic systems. And so one of the issues is, one of the reasons that we're so interested in a long-term collaboration with our partners in local government is the reality that, again, we are not certain where all these nitrates are coming from, and we're not certain about how to address all these issues. And we have older systems, we have failing systems, we have smaller plots of land, and we have people who, in fairness, often can't afford to put in whole new septic systems. So when we talk about the investment in water sources, in investing in municipal systems, again, we have small cities that are not wealthy. And so we're trying to find long-term solutions for just clean drinking water, separation of clean water from septic systems, the ability for people to engage in municipal well systems. It's a long-term plan.
Yeah.
Well, Andre, when you say that though, if you lead that forward to the next logical step is that if someone can't afford to replace their septic and their well, that the government, meaning the taxpayer, should somehow do that, which means now taxpayers are subsidizing people who have purchased a piece of property and they don't have the funds to do so. Why would that be any different than a property owner inside a municipal area or anywhere else? I mean, this is, at the end of the day, there's still responsibility in property ownership, and you get to decide whether or not you want to invest in the infrastructure and the upkeep and the maintenance or not. It is not the government's role to come in and say, private property owner, you don't have enough money, we're going to fix this for you. Not when it is something that is not clearly an outside contaminant that is known to be very specific, and there is a specific entity that has caused this, in which case that there is direct repercussion because you can directly tie it to something that was out of the control of that individual property owner. And I think the PFAS contamination is a perfect example of something like that, where there is somebody at fault versus in a case like this, there's a lot of naturally occurring issues, and it's just a part of owning a property.
Yeah, and I'm not suggesting what the answer is, but we do have really aging infrastructure in our community. And one of the concerns is the impact to all that aging infrastructure on the actual relative safety of drinking water. That's our concern. Really, long-term, how do people remain healthy and safe? And in fairness, if people perceive Yakima County as a place where they can't have safe drinking water, or they're not safe inherently, that becomes a disincentive to people investing here, growing here, expanding their businesses here. It really is about being a welcoming community and a safe community. And honestly, we have aging septic systems, not only in rural Yakima County, but in cities as well. And so it's just a perplexing issue because there's no answer, and it's a massive endeavor and it's expensive. And as you know, the cost of investing in homes is going up dramatically. So.
How long is a septic system good for?
Well, that varies greatly depending on the type of soil you're working with, the type of system, but you're talking a good old fashioned gravity septic system in ideal conditions that's been pumped every 3 to 5 years. 40 to 50 years.
About the age of most of them. Commissioner McKinney, you mentioned natural occurring sources of nitrates. I'm not familiar with them, but could you enlighten me?
Well, as you know, all soils, depending upon where you are in the geology, will have a higher content of minerals and all sorts of things. And so geologists will tell you, and there's actually testing that's been done up above the Shane landfill that on dirt that has never been touched, it's been tested and to have been found high in nitrate. So there's just naturally occurring.
So you're talking about like geology perspective. then?
Yes,
I
and
got
then you also have, I know we've talked about this before, but before we regulated to the point where when someone builds a home and installs the well and a septic, now we know that it's a really good idea to keep the septic and your well a certain distance apart from each other for obvious reasons, which were not so obvious before. And so that is one way that government started to at least regulate a bit and say, you know, for your own good, we really think that you should keep your refuse away from your water source. And that greatly, though, contributes just because you are still having human waste. And that is why, you know, removing the contaminant, known contaminant or possible contaminant may not be possible because the septic's where it's at and the well is where it's at. And that is again where if you're financing property through the federal government, they will not actually lend on a property if the well and septic are too close to each other for that reason. So there's some ways that government can get involved and regulate, but if it's already there and existing, we can't force people to tear it all up and fix it, nor should government come in and do that.
Just, there's a very nice article that reviews all this that I can download and we can distribute to everybody. But some of the points are, it's not just methane with globinemia, but it's increased cancer rates for colorectal, thyroid, and also cause of neural tube defects in developing fetus. So it goes over a lot. It also says about 50% of the nitrates that go into the soil come from agriculture and the other 50% from various sources and like a septic tank pipe that does leaking human waste. So I'll make this available to everybody. I just found it looking it up real quick. So
But you can find a lot looking it up real quick and depending upon the sources that are cited in
this
these
would
articles,
be
it would
the
be
National Library of Medicine.
just saying there's lots of data out there.
Well, some of it's not right, correct, and some of it is.
I would agree.
Right. Thank you, Sean. There's no more questions. Any more questions for Sean? Thank you very much. All right. We'll move into agency reports, starting with Executive Director Andre Pesco.
Thank you for much for the board. Welcome to our guest. I wanted to be brief. We did have a robust conversation on this issue of nitrate contamination. I did want to point out that we're very pleased that we're making an investment in the lower Yakima Valley. This is a long-term process. This is something that we were asked to be a part of years ago by the Yakima County Commissioners when the GWAMA was created. And it's something that we've been involved in from the beginning. It's exciting work because it is representing an investment of government in an area that's impoverished and where often people don't feel seen as free. And so we're very excited to be part of that. It's also a wonderful opportunity for us to work with our local partners. Certainly the drinking water program at the state level. They're located in Eastern Washington, this regional office. But also our partners with the county public works. That's wonderful for me because they're hardworking people who want the best for everybody in our community. So that's really exciting. The other piece is that we are working very hard in our own department on really cross collaboration. So these are departments working together. And so when we talk about a program like this, it may sound like it's environmental, but it's in community engagement. It's the folks in the Williams department. Certainly a tremendous amount of work behind the scenes with Chase and our finance team. It's not easy to put these contracts in place. We certainly have to meet standard. It is government dollars in action. So we're doing this because, again, I think it's a mandate to make certain that people are safe. But it's also interesting because it's additional work. So we're really pleased about these increased partnerships. Really, I want to thank our team. Multiple people are working on these things every day, quietly, in addition to their extra work. So I'm really good. You'll also hear more in our agency reports about our harm reduction expansion in Toppenish, which is going quite well. I won't go into details because Melissa has a lot to share, but again, we heard the board's interest in investing in greater access and opportunity in the Lower Valley, so this is also another. Any questions on that? Okay. And then I also wanted to share that the board had shown interest in a relationship with the Benton Franklin Health District in terms of support for a health officer. I have been in discussions with the administrative team at Benton Franklin. I've now been informed recently that Dr. Aaron Giske, who was the health officer, is no longer the health officer at the Benton Franklin Health District. For reasons that are not clear to me, but again, that's not the case anymore, that the health office there, they've parted ways. And so I need to re-engage with the leadership team at Benton Franklin in terms of the potential for a partnership. We still have Dr. Jay Miller, who's the regional health officer with the state available. And so I'd like to engage the board in the coming months about discussions on that. Again, having backup to Dr. Bard is essential in the event of emergency, both for him and if there's something that we feel is necessary at the health district to ensure the safety of our community. And certainly our medical team and our environmental health team work on the protocols of the health officer, so it's necessary to have. But again, this is a slow moving process, and I just wanted to update the board. If you have any questions, happy to answer.
I just want to remind you, Dr. Bard, that you have no vacation time.
Andre, I guess for me, I know we've been discussing this for quite a few months now and finding some backup. It seems to me that, I mean, it shouldn't be hard to find someone to be on call. So I don't know that we need to wait a few months. I mean, if we want to open up the discussion again to just move forward with potentially a West Side representative being on call, then I would say let's get that taken care of today instead of waiting for months on end.
Well, I can share with you candidly that the idea of having at least a health officer at the state level who could be ensuring that we are meeting standard in terms of care for TB patients or anything related to normal communicable disease day to day, I think is important. We have felt, and we have discussed it again with the state have not, I think, worked through the contract. So the idea was that we would engage on each and every issue and have to sign a contract or engagement letter, which I think is not ideal. And from an emergency response standpoint, there are times when, let's say it's midnight on a weekend, and we need to make certain that we can provide care. That's what's necessary. But again, the board had showed their reticence to have that relationship with the state. What we had suggested was we could have a partnership in Eastern Washington with a health officer and also have as a backup to them, the state relationship. We could engage the state, but I know that there were individuals who have shown resistance to it. So all I'm trying to do is to come up with a plan that keeps us safe, keeps us engaged, and allows us to legally do the work that we are mandated to.
Has WellSouthO ever discussed this as something that they can facilitate internally among their members? It seems to me like that should be.
I know that we talked, Commissioner, about many months on this issue. This is many years on this issue. I had originally engaged and others had engaged in having a more robust, as you said, backup plan that was just worked out. One of the problems I found, Brian can attest to this, but we had health officers who would back each other up, so to speak, but it was a sort of a personal engagement. I was uncomfortable with that because you're talking about an agency engaging in a relationship. So legally, you're actually engaging the entire agency, and the board supports our health officer. So it's not appropriate to just have somebody back up. You're talking about medical coverage as well. So we are a health district. We're covered by an organization called Endurus that does a risk background. So having a health district, another health district is ideal. It's different if you're a county department with a county health officer. It's exceedingly too complicated. But I did try that for years, and health officers were not interested in doing that. They wanted to engage on the organizations they chose to engage. We've also seen, as we've discussed, a lack of interest necessarily in having a West Side health officer cover us. So that reduces the number of health officers that we can have. A lot of health officers were smaller, covered smaller, counties. So Dr. Spitters as an example, and we covered here, the other, we also covered other smaller counties. But they weren't backing each other up. So, you know, this is just more complicated than I think it needs to be, but I'm not in charge of the process. So, we are trying to engage again on options. I'm happy to engage with SOFO again, and I'm happy to speak to other health officers who may be available. It was ideal to work with Benton Franklin because they're down the road, they're a health district, they serve similar populations. There may be opportunities now with the new health officer to do that. And also, in fairness, we have to realize that long-term, we have to start working with Dr. Barr because he won't always be available. And so we'll need to talk about options for the future as well.
So to that point though, and forgive me, you probably have answered this, but like there's the reason we can't just hire someone or put someone part-time in our own backyard in Yakima County. For that exact fact that Dr. Barg may retire at some point. So the idea of having someone locally who's ready to go and step into this makes sense to me.
We could, and often they're called a deputy health officer, so we could do that, we could begin that process, but it would cost money, and we need to have a contract, which again is appropriate, so we could begin that, and the whole point of a deputy health officer is often it allows someone who is not fully experienced in the profession to learn on the job, to have the opportunity. That's certainly an option, and if it's something that the board wishes to engage in, we could do that. I think that that's not a bad plan, but also we've underutilized in the past a health officer relationship. The goal of a health officer is not just to provide protocol oversight, it's to advise hospitals, clinicians, better qualified health centers on things. It's to engage the community on issues. It's to forewarn a community or plan for issues that we know are coming. You know, if we're going to hire a deputy health officer, we want to make certain that there is work for them to do, not just be available in the event that somebody's not able to take a phone call. So again, government in action means spending taxpayer dollars wisely. I'm happy to do so, but I would like to engage the board on a plan for that because it does cost money. And I don't think it's ideal to just have somebody as a backup unless they understand the specific work of public health, which is complicated, like we're talking about. Certainly has to do with things that often are robust investments of time, like a TB patient, or sometimes a medically drug resistant patient. It's complicated. So there's not physicians out there often that want to engage on this who have the experience, but I'm happy to work on that. If the board is interested in that, we could explore it.
I would support that. Get a deputy health officer. It's for many reasons a good solution if the money's there.
Well, we could begin the process of looking at that and then speaking to the board, getting the board's input on how they want to move forward.
I think if you do, then the most important thing would be to know how would you divide responsibilities and how much would it cost? Do we have the budget for it? What does that look like?
And you mentioned that you would want to make sure that they have work to do. So at this point, would you say there is work for them to do?
Well, certainly we can engage on a whole host of topics. One of the things, again, is if you are going to invest in a relationship, it needs to be a long-term relationship. Because again, not everyone is well versed in public health. You often need to have a certain degree or become part of a training program with the state so that you're vetted and you have a mentor essentially at the state level who can train you up essentially to a public health standard. So all those things are possible. We also have engagement issues statewide that need to be addressed. So again, it's good business, and we certainly can create that opportunity. And there is work to do, but it's not the kind of thing that you want to go out to bid each year on. It's the kind of thing where you want somebody who wants to be engaged, who shows interest, who's willing to put the time into that. And in fairness, it means sometimes that means that a health officer has to create that space within their practice to allow them to do that. We cannot be in a situation where somebody refuses to address a public health crisis. So that's something where people often don't want to take the time out of their practice. If they're willing to do so, that's certainly, a clear relationship that we can do.
Well, I don't think we want to make assumptions of it because like you say, the people who would apply would have already made that judgment, especially upon learning what the job description is. So it just seems to me that it would be important to know exactly what the role would be, how much time, what was the commitment, because I also think that it doesn't necessarily need to be, I understand what you're saying, a long-term commitment, but right now we're talking about backup. And I think that there is a place for having someone who feels that they have the ability and the education and the licensure requirements to at minimum be conversing with our health officer and checking in with them once monthly to see where things are and be signing on the line to say, I will cover you when you are gone, when you have something that's going to take you out of the district. So I think, don't overcomplicate. Let's just see first what it would look like at minimum for coverage. And then see if we can talk about what that cost would look like, and then we can go from there.
Sounds good.
I would also still encourage conversation with the incoming health officer to be able to look at both options if that's possible.
Sure. I would agree with that. It'd be good to look at both those potential avenues.
We have multiple options, so we'll work on that, and I'm happy to engage with our partners who have deputy health officers around the state. Sounds good. Thank you for the direction. And that's all for me, unless you have other questions.
If not, then we'll move on. Thank you, Mr. Fresco. To Chief Operating Officer Ryan Ibach.
Okay, for emergency preparedness, our staff recently took part in a tabletop exercise for continuity of operations, referred to as COOP. This is in case, excuse me, this is in case that we had some type of disaster where we, for instance, our building was to burn down. What essential services do we still need to offer the public? For instance, birth and death certificates, we still need to issue those. People still need them. So how would we continue to operate through those? So the tabletop exercise went really well. We were able to continue to identify any gaps, any essential services, and how we would continue on those services. So we didn't find any in our plan. We went over the plan, didn't find any significant. So in case of any emergency, I think we're good. Also today, some of our staff members will be taking part in Columbia Generating Station exercise. This is with Hanford in case there's any type of radiation event on our role and how what we do in that role to protect the public in the Yakima County. And then finally, for human resources, we do have one open position, which we're interviewing today and yesterday for office technician position. And we could have another position or two in the next few months that we'll be.
Ryan, how often do you have drills with the Hanford?
A couple times a year. This Columbia Generating Station is.
Yeah, this is the big one though, where FEMA flies in and actually grades us essentially, so we can't get it wrong. And there's a lot of preparation behind the scenes to make sure that we know our stuff on this Thursday.
Yeah.
Yeah, because tomorrow is the big day, right?
Yep.
Checking my calendar, make sure I didn't miss it. Okay. Anything else?
Nope, that's it.
Any questions? Right, thank you, Mr. Ibach. We move on to financial report from.
Hey, good morning. We'll be reviewing February's financial month 2 of the year. So following along, the packet is on page 7. For the month of February, we had a loss of 66,000, bringing our annual excess to 199,000. Our budgeted revenue through February was just under 2 million. Our actual revenue coming in at 1.8 million. And for expenditures, it's slightly above 2 million, and actual expenditures coming in at 1.6 million. Any questions on the summary? Moving into the financial statements. Again, I'm going to be talking a lot about Foundation of Public Health, FPHS. That's going to be a lot of our funding going forward. So for the FPHS, we play this game every year where we have some funding at the end of the year that we carry over into the next year. We have expended all of our carryover FPHS funding as of February, and we're starting to get into 2024 FPHS funding. Looking into the expenses, the large underages at the moment, enhanced and capital purchases will come out in chunks as we go through the year. We're looking at updating this building by quite a bit of like a big remodel in the building is one of the major expenditures. Any questions on first page of the income statement? And moving into the second page. For the month, our large expenditure for the month was for small tools and equipment. We purchased a bunch of laptops. We're starting to have to re-up laptops. And at the bottom for our FPH funding, we carried over 477,000. We've expended all of that as of the end of February. Any questions? All right, moving into the programs, again, FPHS being our large programs, our large activities, taking up most of this sheet of our play. There's nothing specific I'd like to speak to. Unless there's any questions. Okay, moving into the next program summary. The first quarter for EH, this blue section is generally a very volatile quarter. A lot of our expenditures, we'll spend a lot of time in say food inspections, but there isn't the matching revenue. And kind of vice versa with on-site. There's people are kind of getting geared up for their well sets, but we haven't gone out and done the inspections quite yet. And so this EH programs will start to even out as we go through. Any questions on programs? Finally, the last report being the cash flow. We had an uptick in cash as we expected. Our cash at the end of February is 15.3 million. We received our foundational public health funding in the month of February, and that was the reason for the uptick. And we'll continue to expect that to kind of tick down as we go up until June, July, when we receive that money again, July. I guess if that's no more questions, that wraps up my report.
So Chase, I'll just throw this out there and I don't mean to spend too much time on it, but I do continue to struggle with the fact that we have over a year of operating cash as an organization. And I understand that the health district has a unique issue. And at one point in time, we were fiscally, in issues, but that is a lot of cash for an organization to sit on. And at the county level, we struggle with just keeping 3 months of reserves. So, so I guess the question is I know at one point we were thinking of potentially purchasing a building or doing something, but I assume that we continue to look at options of how to deploy these dollars, because it is a lot of cash to be sitting on.
Yeah, I can.
Go ahead.
Well, we were looking at the building. The building turned out to be not ideal for us. We are looking at an investment in the remodel here, which should cost less money. But yes, I'm going to be coming to you and some options for investments. We've talked about this agency as a community response agency responding to the needs of the community. There's also the idea of being an asset agency. And I don't mean a wallet, but I do mean the idea of investing in the community and investing in multiple initiatives, being able to spur development or options to do so. And those are things that, again, I don't take lightly because it is the people's money, but we have had a series of years of increased options. I mean, you've heard Chase mention repeatedly, surprising to me and certainly many around the table, that we've made so much in investments as an example. So we place our money with the county, it's invested. There's been a large response. We did not anticipate, as an example, that the Foundational Public Health Services work that we've been engaged in would give us this kind of robust funding this quickly. The expectation was it would be a 10 or 15-year plan, and that didn't happen. So the good news is that we've become funded. The increase in savings concerns me. So we'll be coming to you in the future months with some plans for that. The goal, though, isn't to spend down. There's often this idea that there's too much money, so you spend down. I've seen it happen many times in this valley where initiatives have started, but it hasn't continued. And when the money runs out, the project runs out. I don't want that. What we're looking for is to multiply the opportunity, to expand opportunities. As an example, in the Lower Valley. So, you'll hear us talk about things like an update you had asked about mobile services. Rather than having to buy a vehicle, we found other solutions potentially. So again, it's working in our favor in terms of partnerships. But again, we do have this increase in savings that we want to address.
Thank you.
Thank you.
Any other questions for me? Thank you. Let me move on to our hearing officer, Dr. Barg.
Last month, Ms. Ackerman asked some questions about me. Got a nice little preparation. So, roughly for complications, about 1 in 20 patients that are infected with measles will develop pneumonia, which is the most common cause of death for people who get measles. And it's worse in ages less than 5 or greater than 20 years. It's worse in pregnant women and in patients who are immunocompromised from other reasons. Most common complications are ear infections and diarrhea, which most of the patients will recover from. And severe complications occur in about 20% of unvaccinated patients who are infected with measles. They become hospitalized. About 5% will have pneumonia, and it's responsible for most of the deaths due to measles in young children. 1 in 1,000 will get encephalitis and often have sequelae that include deafness or intellectual disability. 3 out of 1,000 will die from respiratory or neurologic complications. In unvaccinated pregnant women who get infected, it leads to preterm delivery and low birth weight babies. And there's also long-term complications, which include a rare but very severe disease called subacute sclerosing encephalitis. It occurs about 7 to 10 years after the infection, so it's probably immunologically mediated and most often leads to death. The highest incidence of that disease occurs in kids that are less than 2 years old and unvaccinated. We have some pictures of measles. Right, so those little red spots you see on the inner cheek, those are called Koplik spots, and they occur a couple days before the patient becomes symptomatic. So when measles was common, pediatricians and family practitioners would look for this if they saw a febrile kid who was, this is pre-vaccination days. You hardly ever see it now until recently. Next slide. This is conjunctivitis. You see how wet and injected the sclera, which is the white part of the eye here, and that's also one of the sentinel symptoms of measles. Next slide. So this is a picture of a rash of a little kid, and the age of the photo is it's old, and that's because that's when you had to go back to find pictures of measles. So in the medical patient description, and Dr. Atterbury will remember this from medical school, you're talking about a particular rash, and it's described as a measles-like rash. And hopefully I won't get to see a real measles rash, but some drug allergies have rashes that look like this, and from the old days, it's described as measles-like. Next slide. This is a close-up of a measles-like rash. And I think that may be the last slide or one more slide. Yeah. And so this is an example of pneumonia, patient who has measles. And the white stuff in between the ribs is abnormal. And you can see both sides of the lungs and the upper and lower parts of the lungs. This can lead to severe hypoxia, which is low oxygen, and eventually death. I think that's the last slide. So the cases are up as of last Thursday. There were 62 cases and multiple outbreaks. There were a few cases in each outbreak. And most of this occurs from somebody coming in from another country who has measles, a country that may not vaccinate as well, or the vaccinations aren't as efficiently given. So for instance, if it's a live vaccine and if it sits around and refrigerated, the potency goes down. So they're like not as efficiently vaccinated as when it's properly handled. And now cases are occurring where the kid has acquired it from one of those situations, and now it's spreading to other kids who are unvaccinated. And as I said last time, you get about 12 new cases for every new infected measles case among unvaccinated. So that's my presentation on measles. I want to move on to influenza.
Dr. Bark, just quickly, the 62 cases, is that a national figure?
That's not a figure. Yep.
I think though, real quickly though, it does speak to, not only is our poor southern border causing many criminal problems in our country, but public health wise, this is a massive issue. And of course, the taxpayers of the United States of America are going to be on the hook for treating all of these people who have massive health issues and are exposing our citizens to these issues.
Dr. Bark, macular papillary rash is still the term that reminds me of measles. So whenever I hear that term, it's immediately comes back.
I can't tell you how many conferences are at, and somebody says, measles like rash. Okay, good news. Flu is finally falling, the incidence of flu in Asia. Syphilis cases are not, they're still going up, and our health district point of service testing, just last week, I think identified 11 or 12 new cases. Sorry. Well, you can read it.
Yes.
So I won't say any more.
I'm excited about it, so.
I would say, no, it's just tremendous how, you know, a population that's hard to access, we're accessing, we're diagnosing, and we're treating. So another, you know, in conjunction with that, at a recent conference, they presented data about a home testing kit for HIV, and works much the same as the COVID test. So you go to a site, you put in your address, and these test kits get delivered to your house. And it allows you, if after some high risk event or just wanting to know what your curiosity is, it can tell you whether you have HIV. And once you know you have HIV, you find a clinic that treats it and you get treated. And once your viral load goes down undetectable, you can't spread it. So in areas where that has been implemented and followed, the incidence of HIV has gone down. There is so far in the United States, 182,000 kits were ordered. So presumably a whole lot of them have been tested. And then the last thing, I think everybody's seen this, is the life expectancy data. So if you want to live longer, move to the San Juan Island. So life expectancy is 86.3 years. The worst county in Washington is Pend Oreille, 74.9 years, and we're at 75.9. King County is 84.6. That's published, and it's interesting. So it's an overall view of how good health services are in the area, and the big things that are worse in the state, in the counties that have shorter lifespans are smoking, obesity, and the inability to participate in physical activity. And all those rates are higher on the east side.
You referenced the county health rankings.
That's part of that. This is a subset of the county health. So just life expectancy is one of the measures. And with that, I will close and ask for questions.
Any questions for Dr. Bard? So how did the San Juans compare to Loma Linda, California?
Well, the interesting is the longest lifespan in the country is around Mono Lake, which is really weird because it's full of contaminants. But that county, Mono County in California, is like an amazing, like it's over 90 years old. So, you know, I don't know if you move there now, whether we'll live longer.
Well, what's important though is what you said is what are the key contributors to decrease life expectancy? Obesity, smoking, exercise, right? Those are all things that, who controls that? The individual. The individual can control their behavior.
It can be altered by education.
Yes, this is true if you make that choice, but that's the same.
You can't make everybody do everything, but
That's
harm
very
reduction,
true.
harm reduction, more education out here, the less people do it, better health is in that county.
Dr. Bard, is there truth to the lifelong gardeners live longer? Gardeners live longer.
Those nitrates that get expensive.
As long as you don't drink their water.
Or dirt. The last time I checked, I don't eat my dirt when I'm out there gardening, so.
Thank you, Dr. Bard. We're gonna move on to, disease control, Melissa, sixth grade.
So I'm gonna have a lot of data today. But first thing I want to follow up on is COVID. I'm sure most of you are aware that CDC had come out with their new guidelines on isolation of domiciliary healthcare. We were waiting for DOH to align with that, and they have since aligned with that. So we are also aligning with the new guidance, which is isolating, if you have COVID, you isolate for 24 hours after you are afebrile without fever-reducing medication and improvement of symptoms. So that's, we're aligning right with DOH and CDC on that. And then now I have a lot of data. So for I'll talk about our harm reduction program in Yakima first. Year to date, we've had 263 unique clients, and we've had 422 encounters. For the month of March, we still have one more day being tomorrow for March in Yakima, but we've had comprehensive has had 58 encounters with individuals, and 5 were scheduled for treatment. And then in Toppenish, on March 5th, we had our first day in Toppenish, and so we've been out there every Tuesday. Yesterday was our 4th Tuesday out there, and we've already seen 86 unique clients and 108 encounters. We started with week 12, or I'm sorry, week 1, we saw 12 individuals, and these were just individuals that were walking by and coming over and getting services. And then yesterday we saw 42, which is more than we saw in Yakima last week. So it's great. We're having a good response out there. We're out there with the tribe. So they have a mobile medical unit out there that they're allowing us to use to do STI testing. They're also getting patients linked into care. Their behavioral health team is out there, and also a substance use disorder program is out there. Tanawit, I believe is what it's called.
Correct.
So they're out there every week with us as well. Last week, we tested 16 individuals for rapid syphilis, and we got 9 positives out of that.
I'm sorry.
For syphilis. So we've been able to identify a cluster or outbreak of syphilis in the community. 50% of the people that we've tested are in their treatment plan, so some of them are waiting for them to come back so we can get them treated, but we're treating them out there in the field as well for syphilis. And then the tribe also out there has given out, I don't have their data from yesterday yet, but for the first 3 weeks had distributed 121 Narcan kits to the individuals out there. Any questions on Toppenish expansion?
On the syphilis, we're doing rapid syphilis test on site, right? And then do we provide treatment at the same time?
If as long as they don't leave, sometimes that's the problem is they'll get their test and it takes, 5 to 10 minutes to get results, and they might leave.
Gotcha.
If they're there, yes. So we've had one individual has actually completed, sometimes they require a weekly dose of bicillin for 3 doses. And so one individual has actually completed all 3 doses already. So we have a nurse that's been going out every week because it's what we're finding. We just didn't expect to have this, kind of response. So it's great. The tribe is letting us use their mobile medical unit, so we're able to have a more robust setup. And also they have a bathroom in there, a functioning bathroom, which is going to allow us to do gonorrhea and chlamydia testing out there as well, which will be able to provide treatment in the field for that as well.
This is primary syphilis?
All of it. But so what we do is we do a rapid, and then we have, if it comes back positive, and we have a syphilis registry for the state to be able to see if they've had syphilis prior, because as you know, it's an antibody test and it's going to stay positive. If they are in that system, we will actually, every single person, we will still draw a blood on them to send it off so we can stage them and know what their treatment plan is going to be. But if it comes back positive, we've had no known previous history of syphilis, then the nurse will treat them right there on the spot if they're stick around.
And are the 9 cases related to one another in terms of not necessarily family, but like the contamination is related to one another, or are they 9 individual cases with no ties to each other?
That's going to be part of the DOH team that does the investigations, so that part will be handed off to them to look, but.
That's a lot. Yeah.
We found that many people have multiple partners.
Right.
And I didn't want to pay my compliments early because again, Melissa wanted to share this information, but I wanted to convey to you that this has been a great deal of work on behalf of our team. Melissa and Ryan worked for years pre-COVID on expanding that, and it didn't work out. We've been very excited about moving forward and frankly frustrated that we couldn't. But this is addressing so many things quickly. The first is, it's a very needy community. There are people with multiple issues and multiple needs, and they're coming in and being very appreciative of the care. It's really unprecedented for a program to start and have this type of reception this quickly, which is wonderful. The community seems very pleased, which is great. But it's also addressing, as we talked about, a need. We're finding a cluster, which is, again, we have incredibly high syphilis numbers in this county. To be able to create a new program and be able to address succinctly a problem in its real-time need is just amazing to me. So I'm really grateful. The other is, it's become quite a highly refined harm reduction program. The number of services we provide, I think, is unique in the state. And so, to the point that the board had shared, is this is more than just needle exchange. It's really about providing services where they're needed. And as Dr. Barg indicated, reaching people who are often not easily reachable by a traditional clinic system. So I'm really grateful to the team.
Yeah, and it's great partnering with the tribe because they have their mobile medical unit is also, they have a nurse practitioner on there. As well as a registered nurse and an MA. So they have a whole medical team out there that can provide wound care, basic medical services to individuals that otherwise wouldn't have services. So it's been great. We're very pleased with how it's going and.
So cases though are increasing?
Of syphilis?
Yes.
Yes, we've been in an outbreak for a couple of years.
And overdoses are increasing.
Yes.
Thank you.
And then also I just wanted to report that last month we had a client come in here for STI testing and reported to our nurse that he used to use our harm reduction site here in Yakima, and in working with peer support services from our needle exchange site in Yakima with Comprehensive, he's been sober for 4 months. So it was a great success story.
Do you have any updated data on referrals that were actually, where the individual actually presented?
I don't have that because the HIPAA and the behavioral health laws. I don't know who shows up. I just know that they're scheduled. That's the only information I can.
No, I'm not very specific. I'm not asking who, I'm asking the data that shows how many people recently updated data who have presented themselves to this program that were referred to services. And of those number of people who referred to services, how many number actually showed up for an appointment?
Right, they are not able to give me that information because it's HIPAA on there and they can't provide that to me. They can't tell me, it's their tracking system and it's just not something that they can provide to
They
me.
can just tell you numbers, can't they?
Yeah, we're just looking.
You
for
don't have to
numbers.
give a name, just say, okay, 5 people were scheduled, 3 showed up.
Melissa, didn't you share that earlier?
Yeah, you've already provided some of this information at previous times.
They were scheduled. I said they were scheduled. I don't know who all shows up to the appointments.
Yeah, no, not asking for individuals, just again, wanting to make sure that we continue to see of the people who are utilizing the program. The point of the program is to see diminishing numbers, and so more people showing up and actually getting treatment and starting down that path, so that we can show that this is a successful program and that we should continue it.
I can't read my writing. Sorry, Melissa, but Melissa shared earlier in Yakima, 58 or 68 had encounters and 5 moved further along in treatment. So is that what you're asking for?
Yes, and so, but then we want to track further, how many of those 5 continue though to actually go through and continue to have treatment?
I can ask them to.
If you're asking, I think who completed treatment?
Not who, how many?
No,
A number.
numbers.
Right, completed treatment.
In order to know that this is a program that is having the impact desired, we need to actually have data that shows that having this program of engagement with low barrier, we're having people on site who are educated and trained to refer, people are actually taking the referrals, they're showing up and they're actually going through to treatment. And we hear more stories about not only 4 months, but 4 years and a lifetime. We have to track that to be able to know that this is a program that is actually being effective and truly preventing and reducing harm or perpetuating. We have to decipher between the two, and that's why data is important.
May I respond to something if you don't mind? I think this is the tip of the iceberg in terms of the number of people who are imperiled in terms of addiction in our valley. So I think that the number of people who are interested in getting into treatment is going to be great, but I don't know if you're going to see numbers reducing. I think you're going to see numbers increasing. So I share that with you in full candor because if the program is working, you're gonna see more people wanting to do it. And so there's gonna be more people coming in. The other is.
That's not true, Andre. To a point, you're gonna have more people and that's the goal. But the data that we're asking for is actually going to show it's successful because of the increased people presenting, more of them will go to will receive the referral, more will go on to treatment, more will successfully go through treatment. And that is the data that's important.
And then the other piece of that, yeah, I agree. I mean, that's the goal is to get people into treatment and recover. But the other piece is, and again, I'm no expert in this, but there are many people who attempt to recover and don't make it fully through a treatment program, and it happens again and again and again. My understanding is you can have people go through that multiple cycles. I'm not privy to answer that. I don't know. You refer, but.
Well, I don't know the statistics off the top of my head, but it's 8 to 12.
Yes, it's a lot, which we still want to know that.
Yeah, that's fine. I
The
just.
data needs to be reflect that, right? Because that is well known. And so knowing though, at least it's getting them engaged in treatment, knowing because it is so incredibly difficult. How did family member go through this? It takes multiple times. And then we have the situation where if they encounter, you know, if they're put in a jail and then they come out and then they, you know, it's all the things. So, you know, but we need to be able to track this, to be able to prove that this is the correct way to address this issue. Or if it is not, we need to pivot and figure something else out, but we cannot do so without the data.
Well, we're happy to look into it. I will tell you that, you know, the bureaucracy of working with multiple programs, it's complicated, but we're happy to engage with Comprehensive certainly. And what they're willing to share, we can share with you.
Yeah,
I think it's worth it. Every life is
I don't
worth
know
it.
why
We're
they
spending a
don't
lot of money trying to make sure that we're doing it as effectively as
Maybe
possible.
just-
Let me ask this.
Yeah, if they're sharing already, how many moved into treatment, they can share the numbers that completed.
It's gonna be hard to like.
Is it completed or actually just showed up?
Well, she already shared how many showed up.
Well, 5 were scheduled.
5 moved into treatment, so 58 had encounters, and the encounter implies there was a service provided.
Gotcha.
So they showed up for treatment, or there wouldn't have been a service provided. The 5 that moved into treatment are in a treatment program. So I'm assuming the next ask is how many completed the treatment program?
My question is, when you're making those referrals, are you making them all to comprehensive health? Because because they're there, or their referrals made to other agencies, other treatment agencies in the community?
For comprehensive, they're being referred to them for themselves. And then we also have worked with Triumph Treatment Services as well, and they can refer to anyone. And then the tribal down in Toppenish, their programs, Catherine Sliskin, I wish she was here. She has agreed to help anyone that comes. Most of the population down there that we're seeing is Native American, but they've agreed to serve anyone that shows up at the harm reduction site and not just tribal members.
So are we then, in light of what Commissioner McKinney is asking, are we able to talk to all of those agencies and referrals we need? To just find out how many actually go into treatment or complete treatment at Triumph, or go into the nation, complete treatment there, or go into.
We can make the attempt, and when we say we're working on it, we're doing this in partnership with other organizations. The board was very interested in people with lived experience, having substance use disorder alternatives and guidelines, if you will. So we're working with multiple agencies. As was indicated, the tribe would refer tribal enrolled members to their treatment program, but also could refer to others. So we can work on it. But again, this is not, the agencies they're working with are not responsible for sending somebody to treatment. It's the privilege of the individual who's seeking treatment to seek the treatment, to encounter. That's their right. So again, some people just get the service, but they don't enter treatment.
Which is why, though, we want to still track at our end, because we want to be certain that this is a program that is having the desired impact and outcome, and whether or not we want to expand it, adjust it, discontinue it, move on to something else. I can't imagine spending this much money on something and not wanting to know if it's actually effective. So I think we should know if it's effective or not.
This is actually relatively new, so that's part of the issue as well. These programs started out in response to the HIV epidemic that was going on, where it was simply just a needle exchange. This harm reduction program has grown so much, and there's not a whole lot of them that are offering peer support services right there on site. So data collection, this is new, and we can work on it and try to get more data, but, you know, Yakima is very unique in offering this service to our clients out there, so.
I think that that speaks to the level of concern that I have, that we have a massive statewide push for this program, for this type of program, and there is a lot of money being spent. And nobody thought it would be a good idea from the outset to begin to have metrics that we're going to track to make sure that this push to turn these, all counties and health districts into providing these types of programs. And we don't want to track it to know if if it's a pilot program. How do you know if it's successful? You want to track the data to make sure that the state taxpayers understand and feel like this is something they want to have their legislature continue to invest in. Well, to me, I don't understand why it's not at a state level. That would be a requirement to receive the funds, that you track the data. But if we need to be the tip of the spear and show that we are forthright and understand that we need to show this information, we can lead the state, that we're going to show that we're responsible with taxpayer dollars. We are understanding what's effective because we want to help solve this problem. That's the whole point. And I think that everybody in this room wants to help solve that problem. But how do we know if we solve the problem if we're not actually tracking it? So I would love to see us provide the state with an example of how to do so.
And I think we're heading in the right direction. I will say, at least on the county's end with our homeless dollars, every provider that we contract with is required to enter data into HIMS, the Homeless Information Management System, right? And so we're getting better and better and better to start to correlate data for how many times is John Doe staying in this shelter versus this shelter and where they're entering, but where the pivoting point where there's opportunity is to try to get treatment programs and track and correlate that data so that we can see John Doe over the course of 3 years, what was that successful outcome that eventually got him out of?
So we can replicate it.
Yes, yeah, so.
And that's part of the problem too, is it's not our data.
Yes, well, and
So
that
it's-
everyone's got their own little system, and so I understand the personal data is an issue, but other counties have had success in other agencies by, you know, having MOUs in place of keeping that integrity. Because at our level, all we're looking for is the data points. We want to see correlation.
I think it's important to recognize that, in models of behavioral change, people are at different phases of trying to bring about change in their lives. So there's this concept of pre-contemplative, contemplative action steps that they're taking. Depending on how many times they attempt to interact with the system, they might be getting further along the chain of getting to action. So though the numbers in raw form might be poor in terms of, you'd say, well, that's an awful lot of interactions for the amount of yield you're getting. You have to understand that the amount of times that they interact with the system, they might be shifting forward toward a better, stronger model for actually bringing about change in their own lives. So that's an important recognition point, because just because they attempted and failed doesn't necessarily mean that in the long run, that wasn't an important step and they're eventually having success. So that's been bore out in lots and lots of research on behavioral health.
Thank you for saying that, because it's very true. This is 58 more encounters we've had with individuals in March than we've had last year in March. So it's progress.
It's a good dialogue. I'll just share something. I was in the Behavioral Health and Substance Abuse Disorder Coalition we have, yes, BHSUD, earlier this week. And we had an individual there who is a person who is a recovering addict who's gone through, you know, he's on the other side of it. And he gave some interesting insight, which is most drug users don't want to be drug users. I mean, which is, it's just that they're so scared to go through often the treatment because the withdrawal is so bad. The symptoms that unless we can give them the reassurance that they actually have someone who's going to help them through, which is the value of having people on site who can speak to that. Anyway, it's I mean, if we give them the opportunities, it seems that we can see success, but we need people who can speak to them. And I would just concur that we've made this a standard practice for us in our county contracts that we seek data. And so and I know that, you know, HIPAA is an interesting animal to work through. I used to be the HIPAA privacy officer at a hospital, so I know what that looks like, but it seems like there's a way to get, you know, the raw numbers.
I'd also like to indicate that the partnership with the tribe is working quite nicely in terms of the distribution of naloxone. That was something that we were doing. The tribe volunteered to do that. I think that's wonderful. But it also means that there's more people in the community with naloxone, which means not only can we save more lives, but it should also have an impact on reducing the number of calls for emergency response. So that's pleasing for me because again, we have a relatively small ambulance pool here in the county. And we have heard secondhand how many first responders and firefighters are responding routinely to people. So again, making certain that our first responders have access to naloxone, which we've worked on this year, and also ensuring that more people have naloxone in the community means hopefully that the number of emergency calls, which will reduce the burden on our governmental services.
Which is an interesting perspective, because yesterday I went to the naloxone training. And one of the things that was clearly stated is if you find someone who's not responsive, the first thing you do is call 911 and tell them what's going on. They'll tell you to administer the naloxone, and then you stay there until the emergency responders arrive. So I'm not sure how many, unless people are doing that just to save a friend and not involving emergency. I think most people understanding the process are gonna call for emergency responders.
But it should reduce the amount of time on site also, which helps. And so
And actually, a lot of people don't, in our responses on our harm reduction, a lot of people don't call 911 because they're afraid. They're afraid of law enforcement showing up and then them getting arrested because they have drug paraphernalia on them or what have you. So a lot of them just administer it. If they're not responding to it, then they'll call 911. But there's a lot that overdoses that the patients are responding and 911 and first responders are never informed of it.
Wondering how that's substantiated. How do we know that, or do we have any idea how?
That's
often
based on the questions that we ask in our harm reduction when we hand out Narcan. Did they call for 911, and most of the time they're not
You're
calling.
asking them ahead of time if they're gonna call 911?
If they did, so when they're replacing their Narcan, we'll ask them, did they use it for an overdose or did they give it to somebody else? Did you call 911?
They have to be honest about the answer, and if you don't have brevity, then don't know. There's no way to track it.
Yeah. Although kind of what I was alluding to, really, there's no way to track that. Only because if you've used the machine once, you're assigned a number, is that correct? So if you use the machine again, you don't have to answer the question?
Oh, you're speaking on the vending machines.
Yeah.
At the harm reduction site, we hand them a Narcan and we ask them a few questions because of the funding, and we're required to ask.
Okay.
specific.
So it's a little different from the machine then, because once they have a number, then they don't have to answer the survey again, they can just get Narcan.
Correct.
Yeah. A little difficult to track.
And then I'll just follow up from last month, Commissioner Curtis, you had asked for some information on rabies. We were able to find that for 2023, we had 51 animal bites, being mostly dogs. Of those 51, we recommended post-exposure prophylaxis to 17 of those individuals, which is 33%. Working with the state, it was really hard to know where we were at with other agencies because there's 3 different data sources that they use to pull that data from. And one of them is where you input vaccines. Some people get rabies vaccines because they're gonna travel, not necessarily because they had an exposure. So it was really hard, and each LHJ puts data into WDRS, Washington Disease Reporting System, differently. Some put it in, some don't. So animal bites aren't reportable. It's the exposures that are notifiable. So it was hard to tell, but what we do is we use a standardized algorithm that was provided by the State Department of Health, and that's the one that we use to determine if we recommend post-exposure prophylaxis. So I would say that having no human rabies cases, we've been successful in that.
Right on. Thank you for that. I appreciate that.
That's in my report, unless there's questions.
Any other questions?
I'm sorry, were we going to talk about the mobile units or would you like me to?
Go ahead.
Okay, thank you. Commissioner Curtis, you also asked about the potential for having homeless mobile units going out. And so we were looking into that and we purchased one, but, you know, ironically, when we first had our first meeting in Toppenish at the harm reduction site, the tribe actually had purchased a medical intervention vehicle. And they're willing to let us use it. So, we've succeeded in having that. We can still explore other mobile, homeless options. I'd be interested in knowing what others think. Again, there's the homeless network, and so I'd like to know what people are needing. That's certainly something we could invest in. My experience with vehicles is you have to have a service plan, maintenance plan. You have to actually use it. If you buy it and it's only used once a month, it's not good government in action. But again, we do have a partnership now at this new site that's working out well. So I'd like to see how well that works in terms of a medical unit that has a bathroom, water, and so forth. And then we can explore that in the future.
What was the thought process
So for
that?
me, I was looking for a correlation because I swear I heard that either Commerce or someone, maybe Comprehensive, got like a grant for a mobile unit to be deployed specifically to address the health needs of our unhoused population. So I was just trying to figure out, well, how many of these things are already going on in our county and what type of services are being provided. So I will, Andre, look into to see who got awarded that funding, because I'm not looking to reinvent the wheel, but just to understand what are we doing to take the pressure out of our emergency room, because as you know, we have a immense backlog and wait time. So that's where my head was at.
Neighborhood Health has a mobile medical unit that they use mostly for vaccines, but they can do all kinds of care on there. I have reached out to them to see if they would be able to have the staffing capacity to be at our harm reduction site on Thursdays here in Yakima to help with that. Because once Toppenish and the tribe get theirs up and going, that's the goal, is that they'll be able to provide medical services out there as well with their nurse practitioner and potentially medication assisted treatment.
Yeah, and I mean, for me, you know, it's data is everything. And so I have had a meeting with Multicare to ask, do they track or do we have data points that you can tell us as far as how many unhoused individuals are entering into the system? And they don't have that yet. Because they're transitioning systems and whatnot, but hopefully down the line, that is a data set that we could get on a quarterly basis so that we know as a community, these are the number of folks entering into emergency rooms that could potentially have had primary care else through other means.
I will comment, a couple of years ago, they did a project that hotspotted the frequent users of the emergency room as well. So that might be something to reference for Multicare that Memorial used to do in collaboration with them. Signal Health.
What did they call it?
It was a GIS hotspotting.
Okay.
I'm sure Mike has that data still.
I kind of wonder if it's in their community health needs assessment too, which they just rebranded and put online. Let me look at it. I have a link.
That would be helpful, because for me, I don't know how big of the problem is. Are we talking 20 individuals? Are we talking 200 over the course of, amount of time? So
The people who are high users to the.
yes, yes.
Yeah.
Who could have potentially otherwise got care elsewhere versus in the emergency room.
I honestly can't imagine they're not tracking it. We're required to track it for payers now as well, so I can't imagine they're not required to.
Let's regroup then, because that would be helpful, because I was told no.
Two updates on that. I do have a meeting tomorrow with the representative from Commerce to talk about this issue. The other is that in some communities, there's been some success with emergency medical systems working in partnership with emergency rooms to actually work with and engage high users of emergency rooms so that they can manage care, manage complexities, any issues around medication. Sometimes you have people who don't keep up with their medication or don't take it at the right time, which creates acute situations. We do have a large Medicaid population, and we do have a lot of people who use the emergency room as their first line of defense. Having said that, I don't know if our emergency medical system could engage with that, because you're talking about a lot of people, and we don't have a county emergency medical services system. We have private providers, but I can also engage with Tony Miller on that issue.
In the past life, coming from the payer side of the world, they do put together population health reports for the primary care providers that do show just that, the individuals that are high utilizers, frequent ED visits, potentially avoidable ED visits based off of time and diagnosis, who those individuals are, how how frequent they've been in there that month. They get that on a monthly basis, so they can drill into every one of those individuals.
I believe the farm workers clinic used to have a program set up with Memorial to where they would get notified if their clients came into the emergency department, and we're able to divert a good percentage of them to available primary care spots in the valley. So these programs exist from the insurer standpoint and from the large clinic standpoint. It's just a matter of getting the data and getting the ER, which you have one, to cooperate with them to try and bring those utilizations down to a more appropriate level, because many of the people get better care in a primary care setting than they would in emergency room for the problems that you're talking about, if it's, you know, common everyday problems.
And
And even
they're
urgent cares.
They're financially incentivized to do so, and some of them very significantly so.
Yeah.
Well, and I think this is a conversation for another time because it's so large, but I will also share with you candidly that we lost a major hospital. And that's not even discussed. And so I think the state has an obligation to invest in our community, because you have one less emergency room, you have dozens, if not hundreds, of specialists who are not here anymore. You had a mass exodus of clinicians, people who had spent decades working here. It's not an ideal situation, and it's not anyone's fault. We literally just have no longer have a major hospital in this community, and that's had a ripple effect. So I'm not certain that any one issue is going to solve this. There needs to be a massive infusion of support, I think, from the state, and I don't think that's happened. So it's a sticking point for me, because it's literally an investment that the state, I think, has an obligation to do.
Are you suggesting a state-run hospital?
No, far from it. I'm suggesting the state investing in resources that allow us to have options that can address the fact that we have so many people in need and actually require help. So whether that's investments that come through a public health system or directly to clinicians, whether it comes to federally qualified health centers like Farm Workers Clinic, what have you, I just think that there's a need for more specialists, there's a need for more services, and to divert away from.
So rather than investing a lot more taxpayer dollars, is what I'm hearing, I think that really, again, government's role should be looking at what are the rules, laws, regulations that are making it not a good business perspective to come to a community like ours and actually run a medical system or a hospital. So I think it money isn't always the answer. I think that there are ways that we can change our laws that create and payment for Medicare and Medicaid. All of those types of things can be looked at, because people aren't going into the business of opening hospitals because it isn't lucrative. They aren't going, it's highly litigious, actually. And so we need to look at the reasons why and see what government's role can be there, versus just saying the answer is to subsidize and try to make it work. Why don't we go to the root of the issue?
You mean like increasing payment reimbursement for Medicaid patients, things like that?
Or working smarter. There are other things that we do that we can actually, I'm just saying, it's not always about spending more money. There are things that can be done that don't involve spending more money that will further incentivize business, private business, to actually solve the problem.
Yakima is the highest county for Medicaid, the Medicaid population that exists in Washington State. You're not meant to make money on Medicaid. You will not make money on Medicaid. Medicaid is your primary source. So without subsidizing, that is taxpayer dollars. I mean, we are paying subsidized Medicaid, however you look at it. So if you're increasing the fee schedule, it is subsidizing. And this is the county that has the highest volume of Medicaid residents. So many of our providers are suffering from that. It's hard to stay in business if the population you're treating is primarily Medicaid.
That is one aspect of it, yes.
I would think that, I know that there are different ways of approaching this, but we have a medical school, a very well-staffed and excellent training medical school across the board in terms of only the doctors, but physicians assistants and dental and all kinds of things, that there should be a way to engage with the medical school to increase services in our community. You know, every medical student of any kind has to go through internships or some kind of a program like that. So how do we act and how do we partner with our medical school to make sure they stay here in this community for their years of commitment and service? I think is one of the things we can look at.
And the probably most effective way for Medicaid utilization to be effective is called block grant utilization. And so you take a block of Medicaid money and you put it toward a project. That's something, Andre, that the state works on continuously to fund different projects. It's taking the same pool of money and allocating it differently to highly effective programs. And it can be an effective tool by which you can keep subsidized clinics open and healthcare facilities open that are serving a high percentage of Medicaid population, well known to every provider and just not enough funds, frankly, to keep up with the need. But they're working on it. I know lots of smart people are working on that.
On one very small bright note, there is a general practitioner who is actually accepting patients right now in the community. And it's Cura, C-U-R-A, Cura Healthcare. And they're up, she's out by Fred Meyer area somewhere, so I've seen her sign up. Her first name is Jennifer, and anyway, so if anybody's looking. Anything else? No. Right, thank you, Melissa, so much. Let's move on to environmental health care, Sean McGee.
Hello again. Just a couple things I want to touch on. Currently, Chase and myself and a few others have been working heavily with Yakima County Public Services on our permit management system, working through updates and upgrades and efficiency improvements to our Acela program, that's the name of it. Currently, we're on premises server for Acela. That's no longer being supported after this year, so migrating to a cloud version of that, and we're exploring opportunities to improve this permit management system to increase efficiencies of application and payment through online portals, things like that, streamlining processes for our customers and for our staff. So we'll be working closely with Yakima County on that effort for the next few months, and I'll update all of you as we get further into that. With the fairly mild winter we got a pretty busy winter, even as far as land development goes, but the real busy season is right around the corner. We have newer staff, so we're taking this opportunity to cross-train everybody extensively to set ourselves up for best success when we start seeing a lot more on-site septic permits and well site inspection requests, and then our seasonal inspections, which will be ramping up next month. So that, and with making our Guama site visits a high priority right now. We're busy and only going to get busier, so we're getting trained and prepared for that. In the arena of solid waste, we're working with the Department of Ecology right now on the technical review for documents for the DTG landfill. We're reviewing the updated operations plans. We're kind of in this back and forth mode with Ecology and DTG right now, kind of getting all the facts and information around different aspects of operations for the landfill, and we're moving through that process. So that's where we're at with that. And with methane exceedances that have been detected at Terrace Heights, those are still there but stable. There's nothing approaching property boundaries or offsite structures. We're working with the solid waste team at the landfill and the consultants on making adjustments and minor repairs to the current gas extraction system to see if that improves methane levels in the monitoring wells to really keep the area as stable as possible until inevitably the new gas extraction system and plans are in place and set to be implemented. So overall, it's good news there, as good as it can be, and the problem's not getting worse or migrating. It's staying located where it has been, and we're just taking efforts to monitor that and keep it under control until we get a system update out there. And that is concludes my updates.
Any questions for Mr. McGee? If not, we'll move on then to our attorney, James Elliott.
Well, good morning. It's rare you get an update from me, but I want to update you on the Caton landfill scenario. So if you recall, Mr. Mertens filed on behalf of the health district a motion for an injunction. The court heard that motion on March 7th and issued an order. I understand from Ryan, you've all, as board members, received a bit of an update in terms of what the court decided, but I want to give you more details on that and talk about it. First, the court decided that right now, this is not a determination that it should make. It essentially said that what needs to happen here is that PCHB, Pollution Control Hearings Board, needs to make a factual determination whether or not Caton is a recycling facility. It's not a decision that the court felt comfortable making at this time. Said as a result, the court's jurisdiction is limited until that PCHB determination has been made. So essentially what happened is the court said, you got to go back and try this now at PCHB. That's where you need to start. So that was the determination made by the court. That's first. Second, talked to Mr. Mertens yesterday. He'll be filing that motion in the same fashion it was filed in the Superior Court, seeking an injunction before the PCHB. He'll do that immediately. So that's second. I want to get into a couple things though, because my guess is your constituents will ask, based on this ruling, why wasn't this filed in PCHB first? And the answer is because probably PCHB would have said, we don't have the authority to issue an injunction. And they would have sent it back to the Superior Court on that issue. So now you may further ask, well, why? Why is the situation the way it is? So the statutes and the WACs are designed essentially that an entity like Caton landfill or another limited purpose landfill, upon receiving information that their permit has been denied, the normal process would be for them to, one, appeal it to PCHB, which they did. But secondarily, normally they would seek immediately an issuance of a stay so that they continue to operate. Caton didn't do that in this situation. Their decision was file before PCHB and continue operating, as we all know. So the health district was put in a position of saying, well, if they didn't do that, so what do we do? So as a result, the effort was made to bring the injunction in Superior Court. The only authority under the statutes I can see that can issue the injunction in the first place. It'll be interesting now to see when it goes before PCHB. So in a normal world, we would have had the permit denied. Dr. Barg did his appeal and review hearing and denied. Normally, it would have gone to PCHB and they would have filed to stay there. They didn't. They chose to continue to operate. The statutes in the system were really designed for someone to operate seeking to stay before PCHB. So essentially now I'll tell you the good news is this. The court has already decided we don't have the authority to decide anything until PCHB makes a factual determination about whether Caton is in fact a recycling facility. So now, as the health district and Mr. Mertens files in PCHB, if they say we don't have the authority, the answer is the court said you have to figure this out from a factual standpoint, PCHB, please do so. So at least it puts in a position where PCHB says, okay, we have to. So that would be the only bit of good news I can tell you in this process right now. So I know I've walked through what the decision is. I've walked through what the next steps are. Hopefully I've given you an explanation why we are where we are. And to the extent now, and my guess is your constituents are asking you, why is this thing still going as it is? Hopefully now you can give an answer, at least a little bit of a better answer. So with that in mind, what questions do we have for anybody that I can help you?
Timeframe for PCHB.
He's going to file it immediately and seek this determination to be made immediately. So the information was gathered. Sean and the team did a great job of getting Chris all the information they needed to establish that this is not a recycling facility. Essentially what Mr. Mertens is going to do is refile everything, package it up and send it to PCHB, contact them and say, give me your most immediate hearing, because we've been basically sitting around for this number of months while they've operated without a grant of a stay and operating on their own. By the way, something the PCHB is probably not aware of at this point in time. This will be the first time they'll be indicated to them, this is somebody who's operating without a permit. Hopefully that means they'll take it on an emergent basis. What that time frame means, I don't know. So that's where we are. Any other questions? All right.
Thank you, Mr. Elliott. If there are no further questions, we will move on to public health partnerships with Lillian Bravo.
Thank you. So I wanted to update you all on two prevention campaigns that we've been working on. They're both scheduled to launch in May, but just for a little bit of background beforehand. The first is focusing on caregivers of youth, so parents of youth, and we decided to focus this first campaign on that, given some of the existing campaigns at the national level called Talk They Hear You. Talk They Hear You is sponsored by SAMHSA. And I'm happy to give that acronym at a later time, but essentially a federal agency related to substance use and mental health. And what that campaign is based on is making sure that parents talk to their children or caregivers, older siblings talk to their younger siblings frequently because they're an influential part of their life. And so what we're doing with this campaign is adapting those messages and putting local faces on them. So bringing in local community members to model what those conversation looks like. So hopefully more parents, older siblings or mentors can feel more comfortable approaching that conversation and ultimately prevent youth from using substances. So we're working on that. We are still filming over the next 2 weeks. So if you know any youth that are interested, we'll be more than happy to work with them. But otherwise, that'll be launching in May. The second campaign is youth-based and youth-led. So we'll be partnering with Yakima Neighborhood Health Services. Yakima Neighborhood Health Services have what they call their youth influencers who will be participating in developing these messages and will actually be delivering those messages as well. What those particular messages are going to be, we're very excited to hear more about, because we of course want to make sure that whatever messages come out are rooted in evidence and rooted in facts. But the approach that's going to be taken is very much going to be led by the youth themselves. So we are looking forward to seeing how that moves forward and ultimately provides a new way to communicate with youth in terms of youth talking to youth as well. So those again will be launching in May.
I believe the Commissioner Lindy has a question.
Yeah, just curious, what here moving forward, what kind of media are you using for this campaign?
For the caregivers campaign, it's going to be all forms of media. So you'll see billboards, there'll be TV, radio, social media. Again, given just the way that people consume media, the majority will be going to online messaging, but there is going to be presence across all channels. And then for the youth base, that'll likely be mostly online based as well, given that that's how youth consume the messages.
Okay, I think SAMHSA is a Substance Abuse and Mental Health Service Administration or
Thank you so
something.
much for the assist. I did not practice that one beforehand. Thank you. Any other questions on the campaign?
Will it be all social media?
No, so for the youth base, likely it'll be online based, so social media, Google advertisement, YouTube videos, things like that. But for the caregivers, we are going to be looking at TV, billboards, radio, and all other print as well, just a multimedia campaign overall. Thank you.
Will it be dual language?
Yes, it will be dual language. It's both campaigns will be dual language as well. So then for an update, as Mayor Byers indicated, we did host a train the trainer for naloxone specifically. That took place yesterday at ESD 105. So what the purpose of the development of this training was, again, in partnership with ESD 105 and Safe Yakima Valley. And again, given our intent to increase access to naloxone, we wanted to make sure that people were comfortable utilizing naloxone. So it's taken several months, but now we're in a place where both ESD 105 and Safe Yakima Valley can actually be providing naloxone when this training is made available. So not only are you getting the information, but you're receiving naloxone at the same time if you request it. And there was 26 participants at this first training, which was a great response. They were only expecting 10 to 15. So it's great to know that people are interested in being part of being able to help other people. It was a wide variety of community members that participated. It included educators, law enforcement, different ministries, just a lot of different community members that are very much aware of the issues in our community and wanting to be a part of the solution. So that was the first event. Again, the intent with Train the Trainer is to provide information to people so they can then train others on how to utilize naloxone. The second one will be taking place in Granger on Thursday. And we are also working on developing a Spanish version as well at the request of a couple different community health worker programs that are interested in doing that as well. We did not start with that because that had not been requested, but now that has been requested. We're going to be moving forward in the next couple of weeks delivering that. And so moving after this point, we are going to have a section on our website as well, where anyone in the community can ask for that training, and we can make sure that they get connected with the appropriate trainer that's already gone through the program that's closest to them and is available. Any questions on that specifically? Thank you. And then just a quick update on, as I referenced last month, the Department of Health embarked on a statewide initiative to provide kiosks, as they're calling them, for vending machines for COVID tests and flu tests to be made available. And that site was that the Yakima Health District worked to find a location for here in Yakima County is in Sunnyside. So Fiesta Foods in Sunnyside has agreed to be the host for that kiosk. And as a reminder, right now they are stocked with COVID and flu tests, but there is that option to include other items such as, well, I know Commissioner Curtis suggested naloxone at the last meeting, but there's also STI tests and different emergency wound care kits that can be made available as well. And so we'll be exploring that conversation with Fiesta Foods after we see how the flu and COVID tests pan out specifically. So that will be placed this week, and we'll have a broader community announcement on that. And then for our other naloxone vending machines, as I had mentioned, starting April 1st, Yakima and OIC will be taking care of the stocking and the inventory for those machines moving forward. And we're able to do so because they're signed up with the State Department of Health to receive naloxone directly. And both locations have indicated they'd like to expand what's being offered in those vending machines, much like the kiosk that is going to be made available with more materials for people to be able to take that just are more in line with what their community is seeking. So for OIC, people are seeking more family planning, well, like the pregnancy tests or wound care kits and things like that. So both locations are going to be excited to take that over and not offer just naloxone, but other things that are available for their community members and constituents as well.
Will we be involved though in having approval on what goes in there?
Yeah, it'll be a discussion. Yes, absolutely. It'll be collaborative.
But my question was, will there be approval from the board?
We were not planning on having anything in there other than the things that were going to be paid for by the state. And right now, I think the things that were being paid for by the state were the tests and also flu. So that's
Yeah.
really all.
For the Fiesta Foods location at this point in time, it's the COVID and the flu test, but as I did reference, there are other things that can be made available through the state site, through the state program. They have a specific set of things that you can choose to add on, such as STI tests. They have date rape kits, but obviously that's going to be dependent on the community need and depending on what the location that's hosting it is comfortable with as well.
Sure, I'm just wanting to make sure that because it's a board decision to put those out there, it should be a board decision to approve what goes in there.
Or we're happy to have a conversation. We're not looking to put anything in there that's complicated. And also, it's being hosted at a store. So, the store does not want to be in direct competition on things.
I have nothing on my mind other than to say that, again, the board should be able to approve what goes in there.
If the board wants to have control over the vending machine, that's fine with me. At a certain point, we're just looking to get services out to the community. But if the board has a position on that, we can bring that to the board.
I would move that the board should have the final say on what goes in the vending machines.
One second.
So, this is actually, new business. Can we take a vote now, or do we need to put it on the next agenda?
Well, I mean, Lillian, have you finished your report yet?
Yes.
Okay,
Thank you.
so unfinished business, we have identified none. So as new business, if you want to identify it as something that can go on the agenda the next time, you can. You've got a first and a second. Sounds like it's open for discussion.
So would you be willing to amend your motion to put it on the next agenda? For discussion and a vote?
No, I think it's relevant and germane. New business also means anything that comes up in a meeting that you weren't aware of. I don't think it's out of line with what was given as an option, but if this is something that other members really strongly feel they need time to deliberate on.
I think I'm comfortable taking a vote now or having discussion. I would be open to that.
Let me ask you, generally speaking, then, is the board willing to kind of suspend the general format, the general rules to have this vote today? By consensus, are we willing to do that?
Sure.
All right, thank you. All right, so we have a motion on the floor by Commissioner McKinney and a second by Lynn, I believe, for the board to have the decision-making authority of what goes into the vending machines. Would you like to address your motion?
No, I just think it speaks for itself. We've made the determination that this is a board decision to actually put the vending machines out there. It seems really in keeping with our authority to do so, that the board should have the final approval.
Would you like to address the motion?
I just concur with that, I think. I just agree with that notion that if it was on us to make a decision to have them out there, then it just makes sense to have a say, you know, maybe it's not that relevant right now, but it could be in the future, so setting a precedence now would probably be a good idea.
Would anybody else like to address the motion?
I think for me, it's always a balance with the board of, you know, when to lean into operations and when to lean out. I'm just curious, what items of concern would we have as a board that would potentially end up in our vending machines that we would want to, one, ask staff to get approval here first? So what type of items do we have in mind?
I have no idea, and that's the point. I mean, we want to make sure that there's discussion, because there could be at some time in a future date where something is proposed and the board may at that time have discussion and they could determine to move forward or not. But without knowing what potentially would be suggested in there, I think ultimately, again, the board is setting health policy for the district. And it should be the final say of the board to determine what is going to go in the vending machines. I have nothing in mind, but who knows what's going to happen. It's all about setting precedent for the future. After you and I are not here anymore, we want to make sure that the board has that authority.
I would also comment that I do agree with Commissioner Curtis, you know, the fine balance of making sure that the board's doing their job, but, you know, then staff also has authority, right? However, we did take a vote on approving the vending machines, and now I'm just also thinking of precedents, which we kind of set that. So now, should we be approving what goes in there? And not thinking, I'm also thinking, well, I don't really know I'm not thinking that something crazy is going to end up in there, but I also don't really know. So just kind of following along with precedents.
Any other comments? Board members?
Does the health district own the vending machines, or does the state own them still? And it's
Well, we're talking about two separate vending machines. So the ones for the naloxone, the health district owns, and then the kiosk that the Department of Health is installing is the Department of Health.
and the ones that we're proposing to vote on with the naloxone, are those the ones that?
Well, it sounds like it's all three that we talked about, because all three could potentially have different items in them.
I took it was our two health district vending machines that as of April 1st will transfer to those business and OIC managing the stocking. That's how I understood it.
That was how I understood it as well, because those are the ones we made an actual board decision on.
I don't believe we would have any authority over the state owned.
Well, I'd be happy to engage the board on the state one too. I really, you know, we're talking about, I don't want to make it too hard. I mean, we could just have it be everything that is vending machine related comes to the board. I mean, I really want to keep it simple, and the board has indicated they're interested in that. So I think that would be the easiest. The other I just wanted to point out is that there's certain things that the state at this point will pay for. So there's certain things that are free that go in there and other things that aren't. So there may be a cost to us if there's something that the board wishes to have in there. But I just keep it simple, and all vending machines can come to the board.
So you're saying that the board would have decision-making authority over what goes into the state-owned vending machine?
You know, it gets a little complicated with who owns the machine, but I think that the state's gonna lead into what we would like to place in the machine. So I'd feel more comfortable not having any complexity or assumptions that the board feels that we're not being clear with the team here, with the board engagement. I just say everything that goes in a vending machine could come to the board's attention.
I'm happy to accept that friendly amendment if anyone else wants to do so.
Yeah, I can't make an amendment.
I know that, which is why I just indicated that someone else on the board would need to make.
Well, I would second that.
Right, I'll make the amendment
Thank
as stated by Andre, but you can put it from me and.
Okay, and I accept that friendly amendment.
All right, so we have an amendment. That amendment that's been made to incorporate all of the vending machines and dispensers in the valley or in the county.
District.
Yes. Thank you. And, so we have, as part of the decision of the board, that's our amendment. I need, first of all, so we've had a first and a second on that. I need a vote on the amendment. All right, so can we do a roll call vote, please, on the amendment?
Yes, if you're in favor of the amendment, please state yes. If not, please vote no. Commissioner Lindy.
Yes.
Dee Dibble. Yes. Daleen Ackerman,
Yes.
Councilmember Carrillo,
Yes.
Dr. Atterbury,
Yes.
Commissioner Curtis,
Yes.
Commissioner McKinney,
Yes.
and Mayor Byers.
Yes. So that is 8 votes for and none against at this point. Right, so motion passes. So we have now an amended motion. So the motion is now that the board would have decision-making authority over what goes into all of the vending machines in the county.
District.
District, thank you, the health district, I thought it was the county.
But
It's the
It
county
is,
health.
but it's a district issue, not a
Yeah,
county
okay,
issue.
so it's the district, okay. So that is our now amended motion that is on the floor. Is there any further discussion of that motion?
Just clarification of the language, you said all vending machines, I think you mean all healthcare related. Cookies and-
We're not in the chips.
Right, yeah, so,
That's Dr.
Health district, health involved, vending machine. into this.
right,
Yeah.
the 3 ones that we're talking about here.
I'd call the question.
Yes, thank you. We have roll call vote, please.
Okay, if you're in favor of the motion as amended, please state yes. If not, please state no. Commissioner Lindy.
Yes.
Dee Dibble. Daleen Ackerman,
Yes.
Councilmember Carrillo,
Yes.
Dr. Atterbury,
Yes.
Commissioner Curtis,
No.
Commissioner McKinney,
Yes.
and Mayor Byers.
Yes. So we have a 7-1 vote, motion passes. Thank you.
Just for clarification then, so for any requests that come in from our community partners, it would be a agenda item then before anything gets moved forward. Is that how the process would look like?
It would come across as an agenda item. Thank you. All right,
With that, I have a.
yeah,
an item.
we have no unfinished business, which is next on the agenda. We'll move into new business, and I know that. Commissioner Lindy doesn't.
Yes, thank you for that, and this is, I would, we have a jail, that is kind of falling apart right now. We have, and the biggest issue, the biggest immediate concern happens to be our piping, our sewer system. Those who are familiar with it, including our friends at Comprehensive Health, know that we've had some issues there where we've had pipes that have burst and it's impacted staff that are working in the jail. We're also looking at the possibility of maybe, we've got some elevators that are out of date and running out of parts and we will be able to fix them and use them. So with that, the reason I bring that here is that I've brought this concern, the piping is a $25 million project and we don't have anything like that, but it looks like we could downscale this project to a size that could fit into hitting the most immediate needs, buying some time, and being eligible for congressionally directed spending. In other words, appealing to, actually, I'm in conversation with Senator Cantwell's office. We've been looking at it to see whether we could find a hole where this fits criteria, and I just got news this morning that it actually looks like it's a reasonable fit, that we could actually submit an application for it, and we have a reasonable chance that, you know, there are no guarantees, but that we could get, we'd be eligible for the funds. So we'll just leave it at that. Anyway, any kind of request like this requires 2 letters of support. And so we're looking at this and saying, well, the sewer system that's collapsing could be a real catastrophic health and safety issue for the inmates at our prison. So therefore, what I'd like to propose, and this is a suspending of the rules, I guess, in an emergency situation, but we have to get this done by end of day Friday to get the letters of support in. So I wanted to ask the health district or the board if you would be willing to offer a letter of support for this proposal, and we could actually send you, I think, some draft language if that would make it easy. But I just wanted to bring that for you. Before you, see if you'd be willing to sign a letter of support. And I don't know if it's best to come from the board or from the health district management, but either way, we just need a letter of support.
It has 2 different purposes, I would think. If you're talking about from the Board of Health, it's again, a healthy thing. If we're talking about a letter of support from the health district regarding an imminent public health concern. That's something that we could address from an environmental health standpoint. So that would be something that we could discuss.
Or we could do both.
The board has the privilege as a board, to write any letter of support or perspective or criticism that the board wishes to.
From an expedited standpoint of the deadline that you mentioned, Ladon, I would suggest it probably come from the health district, because we don't have another meeting for a month, therefore we won't have any action in the time frame that you need. That's good. So I would suggest that the health district draft a letter, and then we can show our support for that letter in suggesting our support of the project to help get federal funding.
So made in the form of a motion.
Yes, right, made a form of motion.
Before we move into a motion, then, we need to have consensus from the board that you're willing to again suspend the rules, to take action on this today. Any
Motion is-
objection to suspending the rules for this item? If not, then we'll suspend them and we'll take a motion.
I would move then that we allow the health district to draft a letter or have a letter of support to for the CDS request that the county is going to make.
Second.
Thank you. So we have a motion by Commissioner Lundy and a second by Commissioner McKinney to have the health district write a letter of support to the senator for this situation. Is that correct?
Yes.
All right. Anybody want to comment on the motion?
Just that it seems like a unique opportunity, and I don't want to waste the opportunity, since we have this imminent problem. I mean, this part is, we've talked about this ad nauseum.
That's not.
Yeah, it's less, it's more unsettling or less unsettling if we don't
Less is more
talk about the details, but it's a problem. And you know, there are limited financial opportunities, but it seems like this is an option where we can at least buy ourselves some time.
I can bring pictures.
Yeah.
See, that's blew up on our team, so we might know.
No, thank you.
Yeah, you know, and 80 as a follow-up, I might follow up with you as well to see if we can get a letter of support from Comprehensive. Okay, thank you.
With photos.
You can email me the template.
Okay, yeah, you bet. We can definitely send you a template. That'd be great.
Yeah, if you want photos, we have
They
photos.
should, sticking to our motion on hand, please.
Yep.
Call question.
Yes, thank you. So, let's, I think we'll probably have a consensus vote. So all those in favor, just say aye.
Aye.
Any opposed? None? Motion passes. Thank you.
Thank you all. Appreciate that. And I'll get you a template.
Yeah.
Oh, send it to you. Okay.
Let me draft template and I'll work with Andre and Ryan.
Okay, we'll do it.
Just one more, Mayor Byers, if I might.
Absolutely.
And this is not a voting issue of any kind. This is just simply a comment or to make people aware of a problem that is existing directly affecting the nation's healthcare, not just the counties. But there was a website hack about a month ago called change.healthcare. For anybody not familiar, I would urge you to Google that and its associated problems that it's creating. But to summarize, and please allow me just a simple summary. Change.healthcare is basically a clearinghouse that matches up individual patients with their payers, with individual doctors, hospitals, clinics, every aspect of healthcare. And so you can think of it kind of like a checking account that clears the bank that runs through, somebody submits a claim, wants to get paid, it has to get to an insurance company issues payment, comes back through the clearinghouse and gets deposited in the clinic. That's my overly simplified version of that. That website represented almost 40 to 50% of all healthcare transactions in the nation. It's a significant, almost $4 trillion of transactions to take place through that site annually. So massive program. It is owned and operated by Optum, which is the owner of United Healthcare, and it was hacked. Now, there is lots of things that we could talk about hacks and our interdependence on computer networks in healthcare and their payment systems. But I will just say that the direct impact on hospitals, clinics, and doctor offices is massive. I can tell you in my own clinic, we have not seen a single payment in 72 days because of this hack. There is no incoming, there is no outgoing, and the bills keep climbing. So every hospital that you deal with, Memorial included, is facing these same issues. This is not the only clearinghouse website, but it was the largest clearinghouse website. So there are others, and everybody is migrating over to others right now, one called Availity. But I will tell you that on the landscape of hacks, that one's next. It's just a matter of the chaos that they create by destroying these websites or bringing down these websites is astronomical. And so I think that we should all be aware of these interdependencies on these systems and our weaknesses in the security of these systems and our EHR vendor products. Electronic health record is what that stands for. So we all generate notes in these electronic health records, and these electronic health records eventually become claims or bills, and then those bills go out through these systems. I just want to make everybody aware because it is directly impacting the ability for small clinics, small hospitals, and medium-sized hospitals to stay open. Many of them, I know from discussing with somebody who was just at the Washington State Hospital Association, over half of the members were going to struggle to make payroll this month. Most of those were small and medium-sized hospitals. The larger ones tend to have more cash on hand, and so they can sustain these outages for longer periods of time. However, it affects everybody. And it doesn't just affect any particular insurance product. This affects Medicare, Medicaid, various VA, generally most of the healthcare systems. I'm sorry, most of the healthcare insurers. And so I just want to make everybody aware because if you hear anything about, well, there's a real problem going on in healthcare or there's a real threat going on in healthcare, the assault that we're facing on a daily basis from cyber attacks is difficult to put into words. And the security necessary in the future is also difficult. But in case any of your constituents ask you about, hey, my doctor's office might close over this, it's a certain possibility, but there probably will be grants put up by different insurance companies and or government agencies to sustain these periods of time. However, there already has been victims to it, closures, and that's probably the canary in the mine of what's potential. And so I just want to make everybody aware of it because very little is being discussed about it for how large a problem it is. And though it's had a few articles, even the Yakima Herald Republic had a small article on it one day. I think that it cannot be overstated the size and magnitude of this problem and its direct effect on the access of our patients to healthcare. So just to make mention of it in the record, so that everybody's aware, and maybe we get some, I don't know, more people talking about it would be good.
I know last week we received letters from 2 of our medical insurance companies, and in the past year, probably 4 or 5 of them, telling them that their system's been compromised, just myself personally.
Yeah, we mentioned earlier in this meeting, HIPAA and it's a reaching product. I mean, when you talk about HIPAA violations of 5 or 10 or 15, 50 or 60 patients, you're talking about a HIPAA violation of 200 million people in this one hack. So it's a significant number of people that you're talking about, and all data is potentially compromised. The hackers actually, Optum paid ransom for one day, $28 million. And they brought the system back up for 4 hours and then put it back down just to show that they could. This is probably a state actor. This isn't kids in a high school.
Probably.
What's that?
Isn't it probably?
Yeah, right. This is almost certainly a state actor. Anyways, it's a major problem. I think it brings about probably a discussion needs to be had on the healthcare national level about our interdependency on these systems and or their security, because it's a major problem. And then maybe, congressional action towards some funds set aside for what will be imminent disasters that take place in the future. Because you're talking about one here, but there's more to come. So anyways, I just make mention of it because I know that it's affecting people in Yakima County in every different way that you can imagine. These systems play a role in both you getting prescriptions at your local pharmacy, to you getting surgery from your local surgeon, to you getting radiology test. Every aspect of healthcare runs through these clearinghouses. So it's an important thing to discuss. And I'll leave it at that just to make you guys all aware.
But all the really smart people say we should move to global electronic digital currency.
I'm not sure about that, but,
We're waiting for the quantum system.
Oh, gosh.
yeah, right. Anyhow, major problem. That was it.
Speaking of hacks, on a small, quite a bit smaller level. Some people through the county, at least 4 or 5 that I've spoken to, people, including people at the health district, got an email from me. It's not from me, just for the record. I'm not addressing you by name and there's not a certain just look at the email. If it doesn't have the email head, it's not me. So anyway, that's all.
You found your hacker, right?
Anybody asking for, any information through your email system is probably a hack. You could just take that to the bank.
Absolutely.
There is no normal information going through email, but.
I did get one of those emails.
Did you too? Okay. Okay. Okay.
Eventually, I didn't send it to TS though. I was like, I knew.
Good.
Yeah.
I thought you were just sending me photos, Ladon, so I didn't know.
Well, we know, don't open Edie's email.
Yeah.
There's
There's
photos
photos.
attached.
Yeah, right.
Well, thank you, Dr. Smith. It's good to bring that out into public conversation.
Sure.
To help people be aware, so thank you for that. Is there any other business on today's agenda for anyone?
Second.
So we have a motion by Commissioner Lynn, second by Commissioner McKinney to adjourn until our next regular scheduled board of health meeting, April 24th, 2024. Which, by the way, is my birthday, so.
Yes. 38.
Any yeah, any objections to the adjournment? If not, then we are adjourned. Thank you.
Thank you, Sam.